And present the next speaker, Dr. Eduardo Bruera. Professor Bruera is the chair of the Department of Palliative Medicine and Rehabilitation Medicine at the University of Texas MD Anderson Cancer Center. And in addition to being a dear friend, I owe him my job to him. So he was the one who brought me to this position. Eduardo, you have the floor. Welcome.
Minutos, Eduardo.
Grazie. Sono felice di essere qui, vorrei soprattutto ringraziare alla Pontificia Accademia per la Vita per il suo sforzo di fare questo congresso possibile. Siamo arrivati anche ieri con la mia moglie, abbiamo ritrovato Roma e San Pietro bianchi e belli come mai. Abbiamo detto questo è un augurio per un bellissimo congresso. Ma domani mattina siamo andati a fare la corsa e ci abbiamo ritrovato a Piazza Navona, il Pantheon e la Fontana di Trevi vuoti come mai. Abbiamo detto questo non è un buon augurio per l'Augustinianum. Ma per fortuna il secondo augurio non era vero e voi siete tutti qui, dunque voglio ringraziare non solo all'Accademia ma a tutti voi per partecipare con noi a questo congresso che aspetto sarà bello come mai. So part of the challenge we are facing today is, and I think if we can have the first, it's the care of the patients who are very ill. And as you can see, bianco come Roma. I hope. So, our patients have a large number of serious physical and emotional problems, and I think stand by.
Preferì il tempo, eh?
Sì. Sì, non ho sparato.
Bellissimo, grazie. So this patient summarizes for us the challenges we face. This patient had cancer, he could have AIDS, he could have heart failure, he could have lung failure, and he had a variety of physical and emotional problems that happened all together. So this patient had multiple clinical problems, and we learned a few years ago from this doctor that great doctors do not pay attention to the disease, they pay attention to the patient who has that disease. However, I work at MD Anderson Cancer Center, not MD Anderson Center for Cancer Patients. And across my window, I see an institution that is in much more trouble than we are because it's the Texas Heart Institute. We do bone, liver, lung. Those guys do heart. You check your heart early in the morning, they work on it all day, you pick it up in the evening, and then it's all done. The reality is that we have focused in medicine on diseases much more than we have focused on patients. And we are doing extraordinarily well in cancer. We're also doing quite well in other diseases that complicate the cancer and the treatment. Where we are having great problems is in the care of the person bringing those diseases. We don't teach it, we don't research on it, and that is where palliative care emerges. We address human suffering. That is what we know how to do, that is our business. And I think that's the root of our success. The patient I showed you came to us with all these problems, physical, emotional, spiritual, and the family is ill. When the patient is ill, all the family is ill. An appropriate assessment and management of the family is part of our challenge. So when a patient expresses high symptom burden, they say that they're not feeling well. Yes, it could be the cancer treatment. It could also be a toxicity of the treatment we're giving for the cancer. But it also might be the loss of a job, the emotional burden, or the divorce they're going through. And all that is part of what happens in the expression of a symptom, in the pain, in the nausea, in the dyspnea, in the fatigue of the patient. We know that there are urgent things and important things, and we need to move from the urgent problems, fix them, so we can go into the important problems. That is part of the success of palliative care. Palliative care looks from the red to the blue, and when a patient comes with little symptoms, it is wonderful because now we can move into the green, into the blue a little bit better. When a patient is suffering near the end of life, all these are dimensions that are contributing to the suffering. That's why palliative care controls symptoms. It controls symptoms because it does not just look at the electrical pathways, it looks at the holistic person experience. We are a fringe movement. The modern movement started in the 60s in a suburb of London, so you should see us as wearing tattoos and nose rings. We are a protest movement from the 60s, when disease-oriented medicine gave up on the patients and they were picked up and taken to little homes and taken care of in a compassionate way with impeccable attention to symptoms. Meanwhile, as we say in Texas, back in the ranch, academic medicine was inventing new specialties. We are 10 years older. However, we were born out of wedlock. We were not born in Harvard, in Royal Marsden, in the great universities. We were born outside, and so the road for us, as we heard from Monsignor Paglia and we heard from the Secretary of State, the road for us was very hard. It was very difficult to get accepted, and it's still overwhelmingly. We know how to control symptoms, but we do not have that access that the other ones have. It's hard to imagine a hospital at a big university without critical care, emergency medicine, and multiple other specialties. The vast majority of places do not have academic departments of palliative care and academic programs of palliative care. So patient-oriented care requires different structures and processes, and those are very frustrating to our administrators. So the problem are not the patients, are not the students, the problem are the bosses. We say that whatever we do in the hospital cannot replace what we can do at home for the patient. Well, what happens when this is home and there is no family? So a balance between controlling the suffering in the hospital and at home is necessary. And sometimes places like this in Mexico can provide the level of support that is not available at home. It's simplistic to say that things can be done perfectly well at home all the time. A harmony between the home, the palliative care unit, the acute care hospital, and the hospice are important. We know that a patient who's suffering a lot needs acute care facilities. We need to be able to deliver care to them in a comprehensive way. And once the suffering decreases, then once the suffering is better, they may have high support or low support. High support are two things: family and money. If you have family and money, then home might be wonderful for you. But if you don't have family and money, then some place with dignity might be very important, and that's why the harmony is so important. The palliative care unit is a sophisticated place for the alleviation of suffering. Regrettably, in the United States, there are very few palliative care units, and they are not growing in the numbers they should be growing. So we're all poor in the area of alleviation of symptoms and suffering. And so that is a very important setting. It's not new. The first palliative care unit in North America was opened 41 years ago. They're old. They opened earlier than many ICUs and many other centers, but it's just that the support of the disease-oriented medicine and academia has not accompanied that. To address suffering, we try to humanize the physical environment. We have teams. As you see, this is our team 3 or 4 months ago, and basically teams are important, where we're all working together. And this is the palliative care unit. This is a team in Edmonton. This is a team in Houston. And we need places where we can have important conversations. We call this a fluoroscopy room, because if the hospital sees that we're using this to meet with people, they would take it away from us. So we call it a fluoroscopy room so that they think they're making money out of this, but we know we're making care, we're alleviating suffering. That environment is an important place where important, sophisticated interventions happen. The family needs to be welcome, and the family needs to be welcome in most ways. however the patient defines the family. Even when the family is members that I personally detest, but we're open to all the family because the family is what the patient calls the family. Palliative care alleviates symptoms in ways that is very hard to alleviate in other settings. Dad and mom had their daughter who was going to get married. We had to convince the nephrologist to dialyze Dad, who had multiple myeloma and renal failure, and we gave Dad some methylphenidate so that he could participate. And there it is, the groom, and there it is, the bride. And they are getting married in our palliative care unit, and there you can see our chaplain, Steve Thorney, desperately trying to show in the picture. But the reality is that is care, and this is a patient who got married. So these are outcomes. These are outcomes of civilization. These are outcomes of what we should be doing, and we should never give up saying that these are outcomes when we confront our leaders and our universities. Sharing moments, sharing tea with our patients and families, breaking care barriers, that is what palliative care does extremely well. So we can alleviate a lot of unnecessary suffering in our settings. We try to go to the communities and break also the barrier between the academic and the home, and going to the homes of the patients allows us to discuss where is the bed, how is the care being given, and suggest ways of caring for the patients in the community. This is the bus round in Argentina, and this is the bus round in the border between Texas and Mexico, where we were able to see patients in both sides. And sharing that, going to places, helps us take a combination of the science and the art of care. When a patient has suffering, they're particularly sensitive to little acts of kindness, not big acts, little acts. Phone the patient, prepare a prompt sheet with questions, sit when you visit with the patient, always put your hands on the patient, examine the patient, offer some audio recordings, ask how they want to make decisions, play some music in the care areas, and try to avoid a waiting room and so on. How do we get that in a disease-oriented healthcare system that does not value little gestures of kindness? Well, we need research, and these are type of studies that we had to do and publish to be able to sustain these practices. And in some cases, in India, where I just returned, putting curtains, avoiding interruption from cell phones, is enough to give the patients a sign that we in palliative care care, and therefore we are particularly aware of little gestures that they will be participating on. Avoiding a waiting room as much as possible, it is important, because people who are suffering, who are mutilated, who are not feeling well, do not like to be sitting in front of each other to be seen. Our hospital said you have to have a waiting room. And so we make a point of showing you this. When the outpatient area is completely full, we make a pride act that the waiting room is always empty. And so we take pictures. This is a day when the outpatient area was completely full. We want to walk people in immediately. We want to put signs on the ceiling where people can see it when they're coming in stretchers, when people come in wheelchairs, when they're very ill. We want the art to be present there. We want to change the lights. Just a little bit of pink cellophane around the fluorescence changes the light and gives them that message. If possible, try to have a bed so that the patients lie down in some comfort, as compared to those examining tables that are comfortable for the doctor and the nurse, but very uncomfortable for the patient and family. And when they get into the room, they see that they're going to be seen by this doctor. And in my case, what it says is, I used to be a DJ. I like soccer and I like very spicy food. That's what they're going to know about me in that television, who's going to see them, so that they see that we're going to be contacting each other as person to person. The team is extremely important in assessing human suffering. And again, in the outpatient areas, where we meet with the patient and family, that's part of the secret to the alleviation of symptoms and the alleviation of suffering. Now, what is the evidence? There are randomized controlled trials everywhere from the beginning of the disease process to the end of the disease process in many patients in different settings, and these are the outcomes of those randomized controlled trials. What can I tell you? The evidence is overwhelming that we alleviate physical and emotional symptoms rapidly. And in addition to that, the evidence is overwhelming that we save millions and millions of dollars, euros, pounds, and rupees. And therefore, let's make sure that you sustain, and please take advantage of me or anybody else to send you evidence that you might need to make your case. This is one of the issues that were raised by Dr. Delgado. What is important to these patients? Well, the first thing is our patients consider themselves spiritual and religious in an enormous percentage with great intensity. And when we ask them in all the priorities of their life, if you see spiritual issues are enormously important when you are sick. And therefore, being able to have our palliative care teams deliver that support is extremely important for the patient and the family. If you look at being at home, it's important to them. It's the number 28 out of 35 priorities. If you ask people, would you like to do that at home? They say yes. When you ask them, how important is this as compared to 35 priorities, it's the number 28. Because there are many things that we need to get alleviation of suffering to make that decision. What do we know so far? Well, we can alleviate symptoms, improve quality of life, we do not reduce survival, and we save a lot of money. So Dr. Dalal looked at these patients and says, what are the quality performance measures for palliative care delivery? And you can see that you can take advantage of already published outcomes that will tell you if you are on the pursuit of appropriate palliative care. There are studies demonstrating that even when you only do it in the inpatient care, palliative care has financial benefits. And I know you will be having some discussions on this. Why are there no palliative care units in every single hospital? Why is it that we do not have palliative care outpatient areas in every single hospital? Patients and families die everywhere, we improve suffering, and we would do better care and save a lot of money. Well, we believe there are cultural issues. And cultural issues are not just of nationality and discipline, or in my institution, cultural issue is making cancer history. So, of course, we don't make cancer history. For a long time, they tried to make us history. And basically, you know that the reality is universities have curriculum wars. What am I teaching? Hepatology, AIDS, diabetes. So many, many years ago, I learned that maybe we needed to try to understand the cultural development of the place where you work to see if you can alleviate symptoms appropriately in your patients. And we came up with a definition of 4 stages of development of the cultural palliative development. The first one is denial. We do not have those problems here. Our hospice takes care of all our problems. We are trying to do research in problems that do not exist. That's the first stage of the development of a palliative care culture. It's very common, it's prevalent all over, and then what you do is you go and measure with 100 patients how happy they are to be dying of their disease. And you will rapidly measure and bring it back to the boss and say, you know what, we do seem to have a problem. As we say in Houston, we have a problem. There's a lot of people unhappy with their death and their suffering. Maybe we should be doing something about that. So you can break through denial, and then you face palliphobia. That is moments of panic whenever the P word is mentioned, and you will face that. And it's most common amongst oncologists, pain specialists, and deans of medical schools. Those people will express it, and they'll say, we will lose patients, this is covered euthanasia, there is no science, this is Medicare fraud. When you have that, it's better than denial, but it is always risky. So what you do there is you talk to 5 or 6 people only, and you tell them, let me see your patients. You don't present to an auditorium like this because you're going to get hurt. You present only after 5 or 6 humanitarian, compassionate doctors send you patients, and you treat 100 patients that they send you, and you show that all those reasons for phobia were totally unjustified. The third is the most dangerous of all stages, is the Pallilallia, when people repetitively nonsense talk about palliative care without any accompanying actions. They send you their patients by thousands, and they don't give you any resources to treat those patients. Collective Pallilallia that affects organizations and governments. Do a study, let's document. The most horrible statement is, this is very important. When you hear that you have Pallilallia, in Houston we had 7 programs that collapsed in this Pallilallia stage because they could not sustain themselves. That's when you have to go and negotiate with your bosses, that you need the resources that the cardiologist, the gastroenterologist, the internist, that everybody else has. We went to our boss and told our boss, we need resources, we're getting overwhelmed. What was the answer of the big boss? Eduardo, everybody's overwhelmed. Everybody arrives at 6 o'clock. Everybody leaves at 7 o'clock at night. And so how could we do anything to measure that? Well, outcomes might be important, but we take a lot of time to see our patients. We spend time with them. So we had an idea that might be useful to you or not. That was, look at the parking records. Because in Texas, all doctors arrive with a car. Otherwise, they don't get to work. There is no public transportation. You need a car. So we looked at the public records of parking, and we found something that we thought was incredible. We went to our boss, and I told him, we got something incredible here. All the doctors arrive around 6 o'clock, but their car arrives at 8:30. And then they leave about 7 o'clock at night, 2 hours after their car. We have to publish this. And my boss said, shut up, Eduardo, how many positions do you need? So make sure that you measure the outcomes that will allow you to make your case. And as I told our colleagues in India, make somebody stand up at the front door of the hospital and see at what time the other doctors come into work or get out of the metro to see how that compares. You don't want more, you just want the same as everybody else has. And finally, palliative. Palliactive is when the appointments happen, when the physical space is there. Now you can alleviate sufferings massively, not just in small numbers. And the defining element is administrative space, divisions or departments, and finally, money. So that is the palliative stage. Before then, you will always be profoundly unsafe wherever you work. So cancer centers should have supportive and palliative care very high. Universities should have departments, not just little chairs, not just little this, big elements that will show we care about humans, we care about suffering, we don't care just about diseases. Who needs education? Our bosses need education. The deans of medical schools, the directors of cancer centers, the presidents of hospitals. And those are the ones that really are the ones who are capable of making the change happen now, not students that they can make the change in a quarter century if they don't die before. We need the people who have the power right now. So patient-oriented care is not interested to the powerful in medicine. The pharma, insurance, hospitals, the barriers to person-centered care need to be looked at with the dean, with the hospital medical director, with the Minister of Health. Those are the ones who need our help and our education. How do you make cultural change? That is the way we had cultural change. The reason why I continued my career and I was able to do my work in Canada and my work in Houston was purely due to the Grey Nuns. When the University of Alberta and the Cancer Center decided this is not interesting, this is not academic, I was blessed by the fact that we had 2 nuns in the board of the General Hospital. And what they said is, ICU, anybody does ICU. Emergency, anybody does emergency. Palliative care is mission critical. So, dear doctors and administrators, if you have to do it, close the ICU, close orthopedics, don't touch palliative care. So sometimes a place that really has a mission is the one that can make you feel that you can't practice person-oriented care and suffering. So everything I've done was started by the fact that I was lucky to be in a place where that principle existed. So I'd like to leave you with a feeling that we can do very well, we can alleviate unnecessary suffering, but it's also very important to understand that the end of our lives is going to be a terrible time. And although we can access considerable relief of unnecessary suffering, don't ever allow a colleague to put pressure on you to turn the end of life into a fun, wonderful event, because that would lead to burnout. It is going to be a moment of great personal suffering. You can do a great job, but I remember a doctor coming to tell one of our colleagues that they had a very important patient with breast cancer, and she was 3 days in the hospital and not happy and then the oncologist came and talked to us and said, this person is not happy, has been there for 3 days. What are you guys in palliative care doing? Why don't you do something better? So we sat down there with smoke coming out of our ears for a while. We went back to the office of that oncologist and said, this patient would not be suffering and unhappy if you had managed to cure her cancer, right? And you were unable to cure her cancer. Now, the difference between you and I is I understand that you are incredibly ignorant as a discipline and are unable to cure the cancer, but you worked very hard at curing her cancer. You need to understand that we cannot cure suffering. We can alleviate it, but not completely cure it. And that way you get a balance between the two, because human suffering is complex, is difficult, and it will happen universally. Thank you very much.